Chapter 350 of Harrison's Anti-phospholipid syndrome. Definitions. Anti-phospholipid syndrome or APS is an autoantibody-mediated acquired thrombophilia characterized by recurrent arterial or venous thrombosis and or pregnancy morbidity. It affects primarily females. APS may occur alone, in primary, or in association with other autoimmune diseases, mainly systemic lupus erythematosus (SLE) or secondary. Catastrophic APS or CAPS is a life-threatening, rapidly progressive thromboembolic disease involving simultaneously 3 or more organs. The major autoantibodies detected in patients' sera are directed against phospholipid and or phospholipid PL-binding plasma protein such as prothrombin and beta-2-glycoprotein or beta-GPI. Phospholipids are components of cytoplasmic membrane of all living cells. The antibodies are directed against negatively charged PLs, including, among other, cardiolipin, phosphocholine, and phosphatidylserine. The plasma protein beta-2-GP1 is a 43 kDa plasma lipoprotein which consists of 326 amino acids arranged in 5 domains. Domain 5 forms a positively charged patch suitable to interact with negatively charged phospholipids. In plasma, beta-2-GP1 has a circular conformation with domain 5 binding to and concealing the beta cell epitopes lying on domain. Another group of antibodies termed lupus anticoagulant prolongs clotting times in vitro, which are not corrected by adding normal plasma. Patients with APS often possesses antibodies recognizing triple nemapalidum phospholipid cholesterol complex detected by Venereal Disease Research Laboratory or VDRL test and characterized as biologic false positive serologic tests for syphilis. Epidemiology. The incidence of APS is estimated to be around 5 cases per 100,000 persons per year. Anti-phospholipid antibody occur in 1 to 5% of general population. Their prevalence increases with age. However, it is questionable whether they are able to induce thrombotic events in elderly individuals. Moreover, 1/3 of patients with SLE and other autoimmune diseases possesses with antibodies, with only 5 to 10% of them developing APS. Pathogenesis. The initiating event for the induction of antibodies is phospholipid binding protein seems to have infections, oxidative stress, and major physical stresses such as surgery or trauma. All these factors appear to induce increased apoptosis of vessel endothelial cells and subsequent exposure to phospholipid. The latter, bound with the serum proteins such as beta-2-GP1 or prothrombin, led to neoantigen formation, which in turn triggers the induction of antiphospholipids. The binding of antiphospholipids in the disrupted endothelial cells lead to initiation of intravascular coagulation and thrombus formation. Complement activation had been also proposed as a mechanism of APS-related fetal injury. Clinical manifestations and laboratory findings. Clinical manifestations represent the consequences of venous or arterial thrombosis and or pregnancy morbidity. Venous thrombosis, superficial or deep, occurs primarily in the lower extremities, often leading to pulmonary emboli. Thrombosis of the pulmonary arteries leads to pulmonary hypertension and thrombosis of the inferior vena cava to Budd-Chiari syndrome. Cerebral venous thrombosis presents with signs and symptoms of intracranial hypertension and retinal vein thrombosis. Arterial thrombosis affects more commonly the arteries of the brain and is manifested as migraines, cognitive dysfunction, transient ischemic attacks, stroke, and retinal artery occlusion. Arterial thrombosis of the extremities presents with ischemic leg ulcers, digital gangrene, avascular bone necrosis, while thrombosis of the other arteries lead to myocardial infarction, renal artery stenosis, glomerular lesion, and infarcts of the spleen, pancreas, and adrenals. Livedo reticularis consists of mottled reticular vascular pattern that appears as a lace-like purplish discoloration of the skin. It is probably caused by swelling of the venules due to obstruction of capillaries by thrombi. This clinical manifestation usually occurs together with vascular lesions in the central nervous system and with aseptic bone necrosis. Liebman sacs endocarditis consists of very small vegetations, histologically characterized as organized platelet fibrin microthrombi surrounded by growing fibroblasts and macrophages. Glomerular involvement is manifested with hypertension, mildly elevated serum creatinine levels, as well as mild proteinuria or hematuria. Histologically, in an acute phase, thrombotic microangiopathy is present in the glomerular capillaries. In a chronic phase, fibrous intima hyperplasia, fibrous and/or fibrocellular arterial occlusions, and focal cortical atrophy are present. Pregnancy morbidity manifested with increased risk of recurrent miscarriages, intrauterine growth retardation, preeclampsia, eclampsia, and preterm birth. The major causes of these complications are infarctions of the placenta. Premature atherosclerosis has been also recognized as a feature of APS. Musculoskeletal manifestations include, in addition of bone necrosis, arthralgia, arthritis, bone marrow necrosis, muscle infarction, non-traumatic fractures, and osteoporosis. Coombs positive hemolytic anemia and thrombocytopenia are laboratory findings associated with APS. Diagnosis and differential diagnosis. The diagnosis of APS should be seriously considered in cases of thrombosis, cerebrovascular accidents in individuals of less than 55 years of age, or pregnancy morbidity in the presence of livedo reticularis or thrombocytopenia. In these cases, APL antibodies should be measured, or anti-phospholipid antibodies should be measured. The presence of at least one clinical and one laboratory criterion is compatible with the diagnosis in the absence of other thrombophilia causes. Clinical criteria include vascular thrombosis, defined as one of or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissues or organ, and pregnancy morbidity, defined as one or more unexplained deaths of a morphologically normal fetus or at or beyond the 10th week of gestation. One or more premature births of morphologically normal neonate before the 34th week of gestation because of eclampsia, severe preeclampsia, or placental insufficiency, or 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation. Laboratory criteria include lupus anticoagulant, anticardiolipin or ACL, and anti-beta-2 GP1 antibodies at intermediate or high titers on two occasions 12 weeks apart. Differential diagnosis is based on the exclusion of the other inherited acquired causes of thrombophilia. Coombs positive hemolytic anemia and thrombocytopenia, livedo reticularis with or without painful ulceration on the lower extremities may also be a manifestation of disorders affecting the vascular wall, such as atherosclerosis, polyarteritis nodosa, SLE, cryoglobulinemia, and lymphomas, and the vascular lumen, such as myeloproliferative disorders, hypercholesterolemia, and or other causes of thrombophilia. For the treatment of antiphospholipid syndrome, After the first thrombotic event, APS patients should be placed on warfarin for life, aiming to achieve an international normalized ratio ranging from 2.5 to 3.5 alone or with combination with 80 milligrams aspirin daily. Pregnancy morbidity is prevented by administering low molecular weight heparin with aspirin 80 milligrams daily. IV immunoglobulin 400 milligram per kilogram every day for 5 days may also prevent abortions, whereas glucocorticoids are ineffective. Patients with EPL or anti-phospholipid in the absence of any clinical event who are spontaneously positive for ACL, anti-beta 2 GP1 or LA, or have SLE are at risk of developing thrombotic events which can be prevented by taking aspirin 80 milligrams tab and hydroxychloroquine 200 milligrams tab daily. Some patients with EPS and patients with CAPS have recurrent thrombotic events despite of appropriate anticoagulation. In these cases, IVIG 400 milligrams per kilogram every day for 5 days may be of benefit. Patients with CAPS who are treated with the intensive care unit are unable to receive warfarin. In this situation, therapeutic doses of low molecular weight heparin should be administered. In cases of heparin-induced thrombocytopenia and thrombosis syndrome, inhibitors of phospholipid-bound activated factor V, such as fondaparinux, 7.5 mg sub-Q daily or rivaroxaban 10 mg PO daily are effective. The above drugs are administered by fixed doses and do not require close monitoring. Their safety during the first trimester of pregnancy has not been clearly established.